Good morning again. Let's walk through pay for performance and value-based purchasing and hopefully get you some context around, yes, the train has left the station. Do you need to make an announcement, Rick?
Yeah, here's Brett again with value-based purchasing.
I think that's the most moving introduction I've ever gotten, Doc. Wow. I don't know if I can continue. All right, so fundamentals of value-based reimbursement. I will run through some overviews of these various models. Try not to get buried in the weeds. Okay, you have some materials in your handouts, and I will be, as we move through this, hopefully appropriately attributing some of those materials to other colleagues, and they are listed in your handout at the end as well. Because there's some technical details that probably it's not going to be incredibly helpful for me to read to you, so you can see some of that. I really am more interested in getting at the why behind these programs and kind of get your minds connected with what the strategic bets are, why we're trying to launch a whole series of experiments in this area, and frankly, just how critical this work is to changing the delivery system. I don't know how many of you read Paul Starr's book, The Social Transformation of Modern Medicine, of American Medicine. Anybody read that, Paul Starr's? I don't have the tail on that exactly right. It really was a chronicled history of the rise of the medical industrial complex during the 20th century. Takes us up through the mid-70s, right before DRGs, but after Medicare and Medicaid enactment. And if there's one thing we know for sure about our healthcare system, is that it responds to changes in the way we pay for healthcare. And I think that's the core bet behind this whole program. And we'll talk a little bit about the various reasons for that. So these are some of the ones we'll talk through and some takeaways. Dave mentioned this yesterday. What is value? Value is quality in terms of patient outcomes, safety, and service. Patient outcomes, safety, and service, divided by cost over time, not on a single unit basis. So that is value, and I think it's pretty accepted in the healthcare policy community that the U.S. healthcare system, at a macro level, has never competed on value for populations. Sure, we'll compete on various components of it. If we deliver a good experience, people may be more likely to come back to our hospital. Some decisions are certainly made on reputation and outcomes that have been delivered. And we're getting better at being transparent about our quality and experience measures. But at the end of the day, the macroeconomics of healthcare still reward volume. And in particular, we know that selected services across the whole continuum bring a much larger margin to our institutions than other services. And that's why we don't see a ton of psychiatric bed towers being added on to hospitals. Okay? And if you actually understood where the drivers or costs are within populations, we would rethink how we deliver some of these services, like, for example, psychiatric services. In our organization, we looked at the 300 most costly patients in commercially insured populations. So this is not Medicare. These are younger, commercially insured people. All right? And they got down to two lists of 150 patients. And if you're thinking through this, one list will be obvious. One was those individuals with a complex cancer diagnosis. Okay? The other list was a group of patients who had complex medical conditions, often with some form of psychiatric comorbidity, and commonly coupled with substance abuse, chronic pain, or what? Narcotic prescription dependence. Incredibly costly individuals. And if we get the economics lined up along these population payments, that's the intent of this whole perspective on value-based purchasing. These are the strategic bets. That fee-for-service reimbursement, in other words, just paying us to do more stuff, to that category of 150 patients that I just talked about, you can imagine how much volume that group can drive. ED visits, hospitalizations, coming to you for narcotic prescriptions, psychiatric crises, service after service after service after service. Strategic bet, fee-for-service reimbursement drives cost inflation in the system. If you want different performance, you have to change the financial incentives. And for a population, high-quality care in the form of care that avoids unnecessary non-value-added utilization costs less for that same population in a year than lower-quality care where there really is no management of handoffs, care transitions, or any realistic attempt to break the cycle of overutilization of services that really are not adding value to those individuals. The last one is that global payments will drive efficiencies in how care is delivered, and particularly global payments that are tied to outcomes for episodes. And that's really what's driving various perspectives and experiments around how do we bundle and deliver a single check for all the services associated with this episode of care, this joint replacement, this acute MI, okay? Or, from a population perspective, how do we pay in a global fashion for all the outcomes safety service for a population over a period of time, typically a year? That's the concept at a very high level of where we're trying to go with value-based purchasing. The challenge is you can't flip a switch and change the entire business model of a $2.7 trillion system overnight. And I'm glad that John mentioned Clay Christiansen's book this morning. There will always be components of our healthcare delivery system where fee-for-service reimbursement is the right answer, particularly around complex solution shop care for things that are not predictable and manageable within an obvious range of variation. Okay? So there will still be reimbursement based on fee-for-service. I don't think in our careers we'll ever see a period of time where that disappears completely. But if we don't flip the table where today just a small percentage of overall reimbursement in healthcare is based on global or bundled payments, vast majority on fee-for-service. In our about $3.3 billion system, over 95% of our revenue from healthcare services is based on fee-for-service reimbursement. If we don't flip that table where the majority of it is based on global or bundled payments and a minority is based on fee-for-service, I believe that we are going to have a tremendously difficult time getting at the cost curve and cost inflation over the next couple of decades. We've proven it time and time and time again. We can bring new technology to the table, which theoretically, if applied to the population that was getting services with the old technology, could lower cost. Laparoscopic surgery for gallbladder removal. Classic example. This is going to dramatically lower the cost and the spending on gallbladder removals. Well, what happened? It made it a lot easier to do a much broader patient population, and spending on cholecystectomy went up after that technology was introduced. Okay? So there's a whole series of strategic bets here that are really what you got to think about, and it's often challenging when you're facing the daily details of having to respond to various payment programs and asking yourself why. There's the reason for the why is that we don't know exactly how to get there, and some markets are more ready for these types of payment changes than other markets. Some have better integration of systems than others, and so we need a series of experiments to try to understand what's going to work across the country. All right, so Medicare physician fee system, PQRS and the value-based modifier, readmission reduction programs, episodes of care, and ACOs. So what's the value-based modifier? Well, one component of the Affordable Care Act requires Medicare to establish a value-based payment modifier that will be applied to the conversion factor for professional physician fees and reimbursement in the Medicare program. They will be starting in 2015 and be completely phased in by 2017. But guess what? The data for the 2015 reimbursement period just started in January of 2013. Okay, so we're already in the middle of it. This is very similar. It's kind of the analogous side to your hospital's value-based purchasing incentives. Okay, these will address both quality and costs of care. And for those who are in groups of 25 or more, like I said, it starts in 2013. And overall, the goal is to align these specific fee-for-service reimbursement modifiers to the general and broader global payment programs. All right. So going into this piece, and I am actually borrowing material from Dennis Beck and Stacy Jones. Dennis is actually a colleague of Dixon's in Denver and runs a billing group and part of a large emergency physician practice. And Stacy Jones is staff for ACEP's Quality and Performance Committee. There's some components here around the value-based modifier, and particularly for groups of 25 or more who use the same tax identification number. If you're not currently submitting data on PQRS, I would suggest that would be a major goal for the next 30 days, is to make sure that you are submitting data with the Physician's Quality Reporting System, or PQRS. This is what it looks like for groups of 25 or more. If you do not report successfully your PQRS requirements, the total adjustment, you'll lose 1% on your value-based modifier, and PQRS is another 1.5% for a total of 2.5%. Okay? And recall, Physicians Quality Reporting System started as Physicians Quality Reporting Initiative, or PQRI, and these are a series of measures where at first the incentive was just you send us your data and we can give you a little extra. Then it's a withhold. In order to get your full payment, you need to submit the data. Now it's transitioning to, depending on how you perform on the measures, will determine how much of your withhold you get back. So that's the same progression that started and went through hospitals on the facility reimbursement, starting with the core measures. And now in their value-based purchasing program for hospitals, they have to perform in order to get their full payment. On the left side of this are satisfactory reporters, PQRS reporters, and then you can elect whether or not in 2015 to have a quality tiering calculation where you could actually get a little extra depending on your performance on quality, but otherwise there would be no adjustment for those who do not choose that election. So here's a lot of stuff on this slide, but I'll just basically want you to get thinking about the fact that over the next several years, the stakes will gradually get higher on programs like these, where in order to receive your full payment or have any opportunity for augmented payments, it's tied to performance, and the percentages go up just like they do for our hospitals with readmissions. Okay? Failure to report PQRS in 2015, based on this year's calendar year, CY's calendar year claims, is a 2.5% penalty. And based on calendar year 2014 claims, it goes up to 3% penalty. So it's very clear that it's important to report PQRS measures. Now the good news is that emergency medicine is ahead of almost all specialties in reporting PQRS measures. 96% of emergency physicians reported to PQRS on pneumonia measures in 2010. So the majority of groups are doing this. I think that bodes well for our specialty. However, we still have some cleanup to do around the technical details, both how we're performing on the measures and how we're reporting them. And the measures are constantly changing. We are striving to get better measures. Jay Shore, who spoke with you yesterday, is our current chair of the Quality and Performance Committee for ACEP. It is an astounding amount of work to try to keep up with all the various measure development bodies, because it's not just that we are the only ones who would ever think of quality measures for emergency medicine. Some of our colleagues from the broader medicine community give us the gift of quality measures that they think we should be doing. All right, so a lot of it is about playing defense and trying to understand that measures really should apply to our environment and to our patient populations, and they're trying to contribute to value over time. So that's challenging. In addition to the quality data, you will be getting your CG CAPS or your HCAPS data, which is your consumer assessment of healthcare providers and systems. The patient experience data will also be reported publicly, coming soon to a theater near you. And actually, CMS has just posted an RFP, and the RAND Corporation, Art Kellerman or others, are working with them to develop an ED CAPS survey. And we've contributed feedback to the emergency department patient experience survey, so we'll have our very own survey, and the data will be posted publicly. All right, so what about readmissions measures? Ed Gaines and I talked about these topics at ACEP in Denver. Some of this content I'm borrowing from Ed. But the hospital readmission reduction program, I've been saying for the last couple of years, this is going to hit hard on emergency medicine, and it'll be something that your hospital administrators are going to be very interested in soon. The baseline period is a rolling 3-year performance window. All right, so it went all the way back to 2008 through June 30th, 2011, and the penalties began last fall in October with reductions of up to 1% of overall Medicare payments. And it was based on performance with these 3 diagnoses: acute MI, heart failure, and pneumonia. The list of diagnoses that are going to be applied to the readmission reduction program is going to grow. I participated in a National Quality Forum committee looking at an all-cause 30-day readmission measure, and that likely is going to be coming around the corner. It's somewhat controversial because certainly hospitals that serve populations where there's a disproportionate share of Medicaid and uninsured patients feel like they're being penalized, and they will be, for performance when a lot of the factors that go into someone being readmitted to the hospital are, at least in our historical understanding of what the role of a hospital is, are outside of their control. I think that's why you hear people like John OBrien saying, I'm really more focused now on overall populations because that's where I have to be focused. 1% this year goes up to 3% by 2015. Just to put that in context for you, every 1% decrease in overall Medicare payments is about $7 million for Fairview Health Services. These are real dollars. This is real money. So if you think about that, there's actually quite a bit at stake with the readmission program. And I know Sherry's going to talk about this in a moment, so I won't spend a lot of time on how to approach that other than to suggest that data, real-time actionable information, and integration between ambulatory and hospital-based settings is absolutely critical to getting at that. Okay? More material that Ed happened to share last fall at Denver around bundled payment programs. This is, again, another series of experiments to say, if we change the way we pay for health care, will we get different performance out of the system? So it's bundled payments for care improvement, or BPCI initiative, and ACE is an acute care episode. As you might imagine, patients with multiple complex conditions can have utilization for a variety of reasons. So defining what an episode of care is can certainly be challenging. Sometimes it's easy, sometimes it's more challenging. It's easier to do with a procedural episode, a coronary artery bypass surgery, a joint replacement, etc., than it is for a medical admission, but they're certainly working on that. You have this chart in your handout, and this just outlines the various components and types of combinations of bundled payments. And it can vary around what part of the episode the payment is expected to address, and whether it's Part A or Part B or both. Part A is the part of the Medicare program that reimburses hospitals and facilities. Part B is the part that reimburses physicians, okay? And some of them are retrospective, some of them are prospective, but there's lots of different models that are being experimented with. Organizations had to sign up in order to do these bundle payment models. You see the little sticker at the lower right-hand corner of this. You may have heard of CMMI, which is the Center for Medicare and Medicaid Innovation. This was established by the Affordable Care Act. That's the part of Medicare that's driving these bundle payment programs, and that's also the part of the Medicare program that is responsible for the Pioneer Accountable Care organizations. So let's talk about ACOs, or Accountable Care Organizations. What are they? They are provider-led organizations or provider-engaged organizations. You have to have physicians in order to have an ACO. A hospital cannot have an ACO with Medicare without some relationship, engagement, and involvement of physicians. Requires a strong primary care base to take accountability for the full spectrum of all the health care needs for that population. And so that is an organization that's saying, you know what, we want to be accountable for the outcomes, the quality, the service, and yes, the total cost of care for this population for this year. All right? And I'll say that there were two huge concerns that CMS wanted to address and policymakers wanted to address when they were launching this program. Because some of you are probably saying, yeah, Brent, this sounds really good. We tried this, and it was called managed care and capitation in the 90s, right? So why did managed care blow up? Okay, we could talk about that for a while as to why there was such a backlash against capitation and managed care. But I think the principal reasons were that the public did not believe that they were going to get the quality services that they needed, and that they felt that the only way to lower the cost of care was to stand between patients and the care they need. That was number one. Number two is that it restricted choice in ways that it's one thing if an individual and his or her family choose to have a narrower network of services available. It's a different thing if somebody else is making the decision and your choice, your freedom of choice is being taken away, right? And then the third thing is that it was driven by insurance companies rather than between care teams and families and patients. We could create a much longer list. But during this whole debate about launching accountable care organizations, two great sensitivities that were addressed were, one, in order to get any shared savings or financial rewards from this program, you have to demonstrate performance on quality and experience measures. We are not going to get to a better delivery system for our populations if the only way we do that is to keep people from getting care that would help them. And I think one key advantage, we can moan and groan sometimes around quality measures, but we are in a much better place in 2013 than we were in the 90s around transparent reporting of public chronic disease measures and patient experience measures, and yes, hospital-based performance measures. One advantage we have in Minnesota is an organization called Minnesota Community Measurement. It's been in place now for the better part of a decade, and all the major physician groups in the state report all of their chronic disease and now patient experience data, and soon total cost of care data, and it's publicly reported. You can just go to the Minnesota Community Measurement website and you can look at how the various groups are doing. Okay? And that's going to help us there. So that's number one concern, which is we have to demonstrate quality and experience. And the second big concern is we cannot restrict the choice of Medicare patients. So they can go wherever they want. So yes, we're responsible for all the costs of the Medicare beneficiaries in our Pioneer Accountable Care Organization. But they can go wherever they want. They can go to Mayo and get care. They can go to our competitors, Allina, and get care if they choose to. Makes it tricky. But it is a response to not trying to recreate the 90s. Okay? So what are these programs? There's 3 basic programs. One really only applies to 6. There was a program called the PGP Demo, Physicians Group Practice Demonstration Project, that took place through much of the last 7 to 8 years. There were around 10 organizations in that. There was an extension of that program called the Physician Group Practice Transitions Program, and 6 of the organizations that were in the PGP Demo stayed with that version. There's a second program called the Pioneer Accountable Care Organization. There are 32 organizations in this. Fairview is one of them. We started in January of 2012, and there are organizations across the country. The last one is called the Medicare Shared Savings Program, and this is the general ACO program for Medicare, and it's exploding. It started last April with 27. Last July, they announced an additional 89. And in January, they just announced another 106 organizations. So all told, there's 260 organizations participating in some form of accountable care organization now. And this is not a panacea. Since we seem to be referencing Clay Christiansen a lot, I'm reading this on the way home. I haven't read it yet. How many of you saw his piece in Wall Street Journal, Clay Christiansen, around why basically these things aren't structured for success yet? So Clay Christiansen, Wall Street Journal, ACO. I just heard about it. Haven't read it yet. I will be on the way home today. But there are challenges with this whole concept, and let me lay out a couple of them. Who's eligible? As I mentioned, professionals and group practice arrangements, networks of individual group practices, joint ventures between hospitals and group practices, hospitals who employ physicians, and then other groups as the Secretary determines are appropriate. If you go on the CMS website, look at some of the LLCs that have been created as part of this Medicare Shared Savings Program. Some very interesting combinations out there. And for those of us who really traditionally, and to a large extent still today, depend on the success of our hospitals for the success of our practice, hold on, because hospitals could easily get disrupted in this. And you think about who would be in the best position to capture a population, manage it. It would be a group of physician practices that don't have to be encumbered with the high expense of operating the fixed costs of a hospital, who are in markets where they have lots of choices of hospitals or specialists to choose from, and then they can move patients accordingly. Okay? Think about that. And Optum and Monarch in Orange County, Southern California, is one organization that's an IPA partnering with Optum, part of United Health Group, to drive this, who has announced that they want to be the largest provider of primary care services in the country. Walmart. We're going to see huge transitions, different experiments, different entrants into this space, trying to partner with primary care physicians who can aggregate a population and understand the analytics and where the costs are going to come from. In any given year, 1% of the population drives 30% of all healthcare spending, 5% drives half of all spending. So much of this is getting your arms around the clinical data, the claims data, the analytics to say, where are the costs going to be in the next year, and how do we be proactive about care coordinating and managing the costs of high-risk patients, as well as very timely with our reactive responses so that we can support patients who are at high risk that you just saw in the emergency department. But if you have a reliable and effective pathway as an alternative to admitting that patient to the hospital, and you're confident that it's actually going to work and it makes sense, how do we react and partner with you so that avoidable hospitalization or readmission can really result in a good outcome for the patient? That's the type of work that this involves, and our healthcare system has not been constructed traditionally to do that. So TCOC is total cost of care, and I mentioned the quality and experience measures in the framework, but if you hold the total cost below a projected target, you can share in a portion of the savings that are generated as long as you demonstrate performance on quality and experience. This is called the ACO 33. It's measures that several which you'll see and will be very familiar to you. Some will be new. Combinations of quality, safety, and experience measures that all accountable care organizations have to report on, regardless of which of those programs you're in. One thing to keep in mind is that all the payments for Medicare beneficiaries, for most of these, are still based on a fee-for-service basis to you and other providers. So no matter where they go, Medicare still pays the fee-for-service payment, okay? But then after the performance period, Medicare looks at all of the data for those who were attributed to you as an ACO and compares the total cost of care for that population against what was the expected spend was. All right? So one component of this is you will be paid by Medicare if you see someone who's part of an ACO. All right? There are different payment models that I think are reasonable for you to review. I don't have to spend a lot of time talking about this, but there's upside-only shared savings, there's shared savings and shared losses, and there's a movement generally towards global payments for populations. These are the 5 years in our model with the Pioneer ACO of how we will be paid at Fairview and other Pioneer ACOs. Okay? So in the concept of global or capitated payment for ACOs, I think in Medicare it's pretty clear that you will be paid by Medicare if you see somebody who's part of those ACOs. It could become very interesting in part of these bundled payment experiments. If you see a patient and Medicare has just paid your hospital, your entity, a bundled single payment, and now they're in the emergency department, it will be interesting to see how that evolves over the next few years. And for as fast as Medicare is moving, the private sector is moving faster. Okay? So we have to keep our eyes and ears open around these risk-based models for patients and for populations. And I agree with John that there's actually a good opportunity for emergency medicine to step out and be engaged and be part of the solution, whether it's reducing readmissions or improving care transitions. You know, the paradox of these is that every dollar of waste in our healthcare system is somebody's dollar of revenue. And we're targeting non-value-added hospital-based services is right in the center of the bullseye for all of these programs. Unnecessary admissions, readmissions, and yes, unnecessary ED visits. Forward-thinking groups are going to be able to think of how they can partner with organizations that are taking on risks for populations to deliver a different dynamic for the populations we serve. You are right at the intersection of ambulatory care and inpatient care. We make the most expensive routine decision in healthcare, which is, are you coming in or are you going home? No matter what happens to the ambulatory care system, no matter what happens to hospitals, you will always be at that interface, and that is a critical interface for all of this work because it's the interface we're really trying to work and coordinate in both a proactive and a reactive way in order to improve care for the populations we serve. I actually think there are opportunities for gain sharing in emergency medicine if you are part of the ACO or part of a bundled payment program or part of the solution around readmissions or part of, just a food for thought as I close, part of being a solution that is cost effective in the acute unscheduled care continuum. Think about it. I've been wrestling now for over 2 years with reforming care models in primary care to improve access and manage populations. And we talk a lot about the patient-centered medical home and healthcare homes. There are tons of great attributes about healthcare homes, but on a large-scale basis, the concept of primary care being able to provide 24/7 access to information in acute unscheduled care is a pipe dream. Okay? And I love my primary care providers. What they do is amazing, but it's a pipe dream. And so we have to think beyond those office hours and beyond the business model of the current emergency department that based in a hospital to say, how do we use the various tools across the continuum of virtual care to deliver more efficient acute unscheduled care in a coordinated and integrated way. So those are a few thoughts. These are some takeaways from this. PQRS, the data reporting is you're already in the barrel for what you'll be paid in 2015. So if you're not doing it, do it right away. Partner with your hospitals to develop quality measure reporting capabilities and systems. We can be part of the solution on these readmissions and watch for gain sharing opportunities with bundled payments and ACOs. I actually think the whole concept of population health is exciting, and you will play a key role in it. And you don't have to be scared when you see ACOs. I do want to acknowledge my colleagues here for some of the material. And you're probably getting a little hungry. Sherry's going to run through readmissions. Is that correct, Sherry?
Yes.
You're good to go? So thank you very much. And if you have any questions, don't hesitate to email me.